For your introduction. Firstly, I would like to thank you for the VNVDA. It's my great honor to be the speaker for the several years for this conference. Today, I would like to talk about the endovascular strategy in the CLTI, the real world practice from Thailand, from the Thailand doctor experience and my experience too. I don't have any potential conflict of interest for this conference. Firstly, as you know about the base CLI trial is a landmark RCT comparing the surgical bypass and EV3. For the infrainguinal CLTI, if the patient with the adequate GSV, the surgical bypass showed a better outcome, and without the adequate GSV, the outcome was similar between the surgical and EVT strategy. And both strategies had a similar safety and improved quality of life. And for the next big trial, the Basil 2 trial, that showed the infrainguinal CLTI that requiring the infrapopliteal revascularization with or without femoral popliteal disease. Endovascular first strategy showed the better amputation-free survival than the vein bypass first treatment for the Lancet publication. Its driven of benefit showed the lower amputation-free survival and higher mortality in the vein bypass groups. So the four patients suitable for the both option BTK with BTK revascularization. Now we favor for the endovascular first approach. For the cost effectiveness, the EVT is more cost effective, particularly in UK and NHS setting. And this is the decision making for type of revascularization from Thailand, from current evidence base. From the individual factor, firstly we use the comorbidity, surgical risk and life expectancy of patient. Second, degree of tissue loss or symptom. Third is the availability of the autogenous vein, especially for the single segment GSV as the base CLI published. For the morphologic distribution of PAD, firstly I use the task 2 or the glass classification, and now we add the BTK lesion from the Basil 2 trial to decision making to do the EV3. As you see in this angiography for the my patient, this patient showed the major tissue loss with the diabetes and ESRD, show the BTK occlusion, and for the foot level also show the BTA disease. For the case like this, it's very common in Thailand, so it's very difficult to do the bypass, and the bypass may be the poor outcome because the poor run of vessel. So this case, I use the balloon angioplasty with the stenting for the selective stenting, and we can do the pedal pantaloop BTA vessel after EVT. So the difference from the open surgery, EVT can correct the runoff for the distal BTK and BTA lesion. So now, why is EVT increasing preferred for CLTI in Thailand? Thailand is the one of fastest aging country in the world. Senior population quickly approaching about 30% of total demographics. So now, Thailand entering to the aging society, elderly and high-risk patients increase. Thai CLTI commonly involve diabetes, mainly BTK lesion from the Basil 2 that support the EV3. So in Thailand liver practice now, about 80 to 90% we undergo the EV3 or hybrid procedures. Why? About 20% is require open surgery alone. So the EVT is the minimal invasive, faster recovery, and less need for the general and spinal anesthesia that ideally for our patient, the frail, elderly, diabetic, and high surgical risk patient. And now we have advanced technique, operator experience, and device that can improve the EVT outcome. And we reserve the open surgery for the average risk patient with the good GSV conduits with the good BTK and BTA vessel runoff. And this is our EVT algorithm for the FEMPOP and BTK lesion. The important step including the vessel preparation that allow the maximal lumen diameter without limiting dissection. The second important step is the definitive therapy of arterial occlusion, DCB stenting. And this is the available device in Thailand now. We have the POBA specialty device, scoring balloon, stent scaffolding, DCB and atherectomy, and intravascular imaging. The question is how to maintain the patency and improve the clinical outcome limb salvage by the endovascular treatment in Thailand. The answer is the proper device selection for the right patient, and the right region can improve vessel patency and the limb salvage rate. We start with the POBA. As you know about POBA is the poor primary patency. One year's primary patency may be only 45% because the POBA alone cannot address dissection, cannot provide the scaffolding, cannot resist the acute recoils. And after POBA, the angiographic result will determine the definitive treatment, such as the DCB and scaffolding. For the no dissection, no recoils, we use the DCB to maintain the long-term vessel patency and prevent restenosis. For the limiting flow dissection or acute recoils, we use the stent or scaffold. This is mandatory to improve the immediate to midterm patencies. And for the DCB, in Thailand now we have the paclitaxel coated balloon and sirolimus coated balloon. And this table show the difference between paclitaxel and sirolimus DCB. Mainly, the DCB is the extensive evidence for the femoral popliteal lesion, multiple large RCT, FDA approved guideline recommend as the first line of DCB in fem population, and the 1 year patency about the 80%. But for the sirolimus DCB, the Sirona trial, the RCT show the non-inferior when compared with the paclitaxel. And for the BTK evidence, the paclitaxel is still weak evidence, no FDA approval, and the trial show the negative results. So the major aswelling event in BTK may be not improved by the paclitaxel. But for the sirolimus, now they are the Saritphat trial that show the superior to the POBA alone that just report in New England Journal of Medicine in this year. And there are lots of ongoing dedicated BTK trial for the sirolimus. For the mortality safety, for the paclitaxel, the controversy is resolved, no problem excessive risk, and no signal for the sirolimus DCB. And for the stenting, we have the self-expandable stent, interwoven nitinol stent, duct-eluting stent, and cover stent. And this is the ideal feature for the stenting: flexibility and torsion resistance, low conic outward force, high radial resistive force. To prevent the problem, stent fracture, chronic vessel irritation, poor luminal gain, and stent collapse that's caused of the instant restenosis or the occlusion, endothelial trauma, and neo-intimal hyperplasia. The indication of stent in our practice, we use only for the limiting flow dissection and stenosis that cannot correct after the reballoon, atherectomy, or any device. For the stenting, the vessel diameter we deploy under the 1/1 size to low conic outward force and maintain the optimal luminal diameter with the high radial resistive force. For the stent, the thin stud stent is shown the low ISR to prevent the NIH. However, no perfect stent. The thin stud stent may be cause of stent fracture, especially for the popliteal region. And this is the comparison between the stent that available in Thailand. We have interventional nitinol stent, DES, and stent graft. Mainly for the superior, the base lesion type is calcified angulate popliteal segment. For the DES, for the moderate length and low calcification. For the stent graft, in some cases we use the stent graft for the long segment and the ISR. And however, the benefit of superior is shown, as you know, in the lung symposium, fracture resistant and very low the stent fracture rate. And because of it's created from the Y, it may be cause of neo-intimal hyperplasia because it's no antiproliferatives. For the DES, the benefit is can reduce the neo-intimal hyperplasia by the drugs, but may be risk of stent fracture, especially for the popliteal region. For the stent graft, the fracture resistance is also explained by EPTFE lining, heparin sulfate only to prevent the neo-intimal hyperplasia and exclude the neo-intimal hyperplasia between the start by the EPTFE already, but it's also caution in the joint flexion and maybe cause of thrombosis when it's kinking. And for the arterial calcification, as you know, it's cause of mechanical effect, the barrier to the optimal dilatation of POBA with the poor vessel preparation, and it's cause of severe dissection and recoils. For the pharmacological effect, it's barrier to the drug absorption, including the DCB and DES. And calcification, it can decrease the primary patencies. The circumferential distribution of calcification is strongest influencing factor more than the length of calcification. And this is the show the poor vessel preparation by the calcifications after the interventional stent. It may be cause of elongation or stack that's cause of the poor patency of stent, because it may be loss of radial resistive force on the compression resistance, decrease of minimal stent area, and high in-stent restenosis. So the vessel preparation before the stenting is very important. Like this case, this is the my Thammasat University case. Baseline show the some stenosis and calcification. I do the POBA and scoring balloon to vessel preparation. You will see in the calcification in the one side of the wall. And for the scoring balloon, it can Wales luminal expansion. And after the POBA, the vessel was prepared for superior deployments. And this magnified after post dilatation, they show the good optimized good geometry of the superior. That's cause of the good patencies. The next device for the calcified lesion, including the specialty balloon, scoring balloon, and atherectomy debulking device. In Thailand, we use both of device. For the dissection and recoils, as you know, after the POBA, the balloon will fully inflate, but the high risk for overstage of contralateral plaques and free wall non-diseased segment may be cause of dissection, recoil, or rupture in this area. And the risk of dissection, risk of rupture, as this case is my case. After balloon dilatation like this, is cause of the extravasation in the one contralateral plaque free wall. For the specialty balloon, we have the scoring focal pressure balloon that can create a contour dissection. It can improve the luminal expansion, control the risk of recoil, dissection, rupture, and can improve pharmacological effect that we use for the low-grade calcification. And it can also increase the drug uptake and reduce barotrauma. And for the atherectomy, now we have the directional atherectomy, rotational atherectomy, laser atherectomy, and orbital atherectomy. It can prepare for the drug delivery and change with the vessel compliance. It can crack the hard calcified atheroma. That's good for vessel preparation. However, is some disadvantage is the risk of distal embolization of the active debris, routine use of large size, increased procedural time, and some publication also show similar patency rate and the TLR. So we preserve the atherectomy device for no advanced age patient under the leave nothing behind concept for the TAS C, TAS D lesion, occlusive lesion that can pass the wide intraluminal approach. So it may be need the intravascular ultrasound to confirm before and non-stent zone region, especially for the common femoral artery and popliteal artery in the well-ambulated patient. The last device is the intravascular imaging. Now in Thailand, we have the IVAS and the OCT. Mainly I use the IVAS, and this is my publication in the last 2 years from HJVAS. We include the IVAS show the larger vessel diameter than angiography for the frame pop about 10%, BTK for the 20% significantly. And this is the my practice for to use IVAS. I use IVAS to scan and plan to the wide confirmation intraluminally, characterization deletion, and measurement the accurate diameter of vessel, especially for the BTK vessels. For this case, the BTK show the totally occlusion of popliteal bifurcation. After the IVAS, we use the balloon angioplasty that measure the size by IVAS in the proximal to mid PTA. And after the balloon angioplasty like this, as you seen, the vessel runoff is good, but we seen the something in the proximal PTA. What is this? Dissection? What is grading or dissection from this angiography? Or thrombus? And this is required stent. After the balloon again and again, we cannot correct this lesion. So for this case, I use the IVAS. IVAS show the focal dissection flap, the mobile flaps deep to the media. So the case like this, I use the stenting. So the IVAS can help you to decision making to do the stent or not stent in some area that maybe not need to stent or need to stent in the to maintain the patency for the future. For this case, I use the sand palm in the proximal PTA to correct the dissection flap. And finally, the result is good. and use the IVAS again to after the stenting to assess the stent expansion position and the aid pathology. There is no any disease in the stent area. For the IVAS, there are the RCT from the Korean country that show the good outcome. The IVAS guidance show the better primary patency and freedom from CDTLR, and benefit from IVAS is especially clear in the complex lesion. I mean the complex task C to D lesion. However, for the task A to B, just the short stenosis is maybe not different. So the result for this publication, the difference for the task A and B show the small and non-significant. And this is my Thammasat University Hospital, Thailand clinical result. The one 92 limbs, I use the IVAS compared without IVAS or angiographic alone to do the balloon angioplasty that show the 3-year and 5-year primary patencies prefer the IVAS guide significantly reduction in the risk of losing patency. And I do the subgroup analysis for the DCB. For the DCB, the IVAS also show the benefits, especially for the 2 years and 3 years at 10 to lower amputation rates and comparable of mortality rate. And so this is the latest meta-analysis. The large-scale meta-analysis from 19 studies confirmed the IVAS significantly reduced the risk of binary restenosis, reintervention, amputation, and primary patency. So mainly in Thailand, I do the IVAS for the complex task C and D. And this is the short case presentation CLTI to demonstration the real practice and case in Thailand. Very advanced age, 86 years old, females, the left first gangrene with the rest pain, diabetes and CAD. Just do the PCIs and history of left femoral artery cut down with PET angioplasty to treat iatrogenic CFA dissection when the PCI in the last 1 year in the left side. And right BK amputation due to the diabetic foot infection for the last 10 years. However, she is still active ambulation by walker. So for the left limb now is very important for her to ambulation to quality of life. We do the CTA angiogram, show the CTA in the left proximal SFA to the mid SFA. You will see the some calcification in the occlusion area and show the total occlusion of distal popliteal TB trunk proximal ATA and faint reconstitution of the contrast in distal BTA and distal ATA. This is the commonly presentation in Thailand, the multi-level disease, the calcification disease with the advanced age patient. So this case, I do the contralateral CFA puncture, identify distal SFA reconstitution. However, I failed to integrate approach, so I do the technique to retrograde puncture of distal SFA under fluoroscopic guides. And because this calcification, I start with the P-dilatation and use the scoring balloon in the occlusion area. And finally, because the dissection and calcification can open, but a stent is needed to correct some dissection in this area. So I do the intravenoidal stent as I present before. That is based for the calcification lesion. And I do the catheter-based BTK angiographies that show the occlusion of the distal popliteal, proximal ATA, and TP trunk occlusion, and very faint reconstitution in the distal ATA and PTA. For this case, I concern about the patencies, not only the wound healings, but for the long terms. I do the retrograde puncture for the ATA under fluoroscopic guides and success to pass the Y to the SFA and balloon angioplasty. However, I cannot open the PTA, so I do the retrograde puncture, the PTA, and pass to the popliteal artery. Finally, after the single balloon angioplasty, also show the plaques is displaced to the another vessel. When I do the angioplasty in the ATA, the PTA also recurrent stenosis. So in this case, I do the kissing balloon angioplasty, and I confirm the intraluminal wise placement by the IVAS because the bifurcation balloon angioplasty, the intraluminal approach is very important to prevent the dissection and occlusion of the side branch. So I do the IVAS measurement for this case and kissing balloon angioplasty, and then we use the DCBs with the sirolimus as the sirolimus is also prefer to do the BTK angioplasty. And in finally, angiogram is not seen any complication for the puncture size and could run off, but not to the wound. Normally, I try to do the angioplasty until the contrast to the wound, or we see the wound burst at the wound dosome concepts. So in this case, I do the pedal angioplasty that cannot do by the open surgery. And this is the final result for this case. The wound was healed in 3 months. And for the summaries, endovascular strategy in CLTIs. Endovascular era is ideal for aging society, high-risk patient, complex BTK disease pattern, advanced techniques, experience, and device for vessel preparation and definitive treatment for the lesion is can improve the outcomes. Proper device for the right patient and the right region is the key for the limb salvage rate by the EVT in CLTI. And for the open bypass, we reserve for the average risk patient with adequate vein conduit with a good run of vessel to the foot in CLTI. Thank you.